Restrictive Cardiomyopathy, RCMP. Definition: the major abnormality is restriction of ventricular filling, thus an increase in filling pressures. The usual abnormality, impaired relaxation and compliance. In contrast to constrictive pericarditis, CP, LV and RV, diastolic filling pressures are discordant in RCMP, but concordant in CP. Discordant means the hemodynamic phenomenon of dissociation between LV and RV diastolic filling pressures during inspiration. Concordant, parallel changes in both LV and RV diastolic pressures during respiration. Classification, ETI. 1. Primary, A. Lafleur's endocarditis, B. Endomyocardial fibrosis. 2. Secondary, A. Infiltrative diseases, B. Storage disease, C. Post-radiation disease. RCMP. Primary characteristic is inflammation, due to parasitic infection, autoimmune diseases, eosinophilic leukemia, and eosinophilia associated with chronic inflammatory processes. Systemic form is classified by the specific type of material, amyloid, sarcoid, hemochromatosis, neoplasm, deposition, EA, infiltration, storage or replacement. Primary form, the most important cause of asthma is endomyocardial fibrosis, EMF, which is seen in tropical regions. Another form is, called acute form, hypereosinophilic heart disease, Lafleur disease. Amyloid deposition of myocardia may not be associated with systemic amyloidosis. West of the world. Specific heart muscle disease, this form, usually produces dilated SM with impaired both systolic and diastolic function. Sarcoidosis, hemosiderosis, eosinophilic syndromes, scleroderma, adriamycin toxicity, infectious diseases including tuberculosis. Restrictive pathophysiology, may be at pericardial, CP, endocardial, EMF, or myocardial, HCM, level. Restrictive/infiltrative cardiomyopathy, the gross image on top shows a heart with marked EMF which prevents diastolic compliance of the LV. Note the markedly thick, white, endocardium. The lower part of the panel is a heart with patchy/white areas involving the ives from the base to the apex and continuing into the free wall of the LV owing to infiltration by incussating granuloma in a case of sarcoidosis. RCMP, pathophysiology. Increased ventricular diastolic pressure, decreased filling, and the clinical endpoints. RCMP, clinical presentation. Intermittent fever, dyspnea, cough, palpitation, edema, tiredness. Eosinophilia with abnormal eosinophil degranulatans seen in temperate climates, Lafleur syndrome. Eosinophilia is less severe in tropical EMF. S3 or S4 gallop may be visible and audible in the absence of HF. Symptoms and signs of HF and of moderate to severe MISTA and TR owing to involvement of the papillary muscles serve differentiate arson from CP, as does the greater degree of cardiac enlargement on chest X-ray in the former condition. Chest radiogram, calcification may be seen on RV or LV apical myocardium in EMF. Echocardiogram, A, shows obliteration of apices of the ventricles by echogenic masses, lichen boxing lump. B, numerous echogenic areas are usually observed throughout the ventricular myocardium. C, also, myocardial calcification may be detected. D, and in later stages, MISTA and TR. ECG, non-specific. St. T wave changes and LVH may be present. ASM, ECG. ASM, treatment. There is no standard and effective therapy, no medical therapy guidelines. Steroids, beneficial in early inflammatory phase of hypereosinophilia. Hydroxyurea and vincristine are also beneficial. Anticoagulation is needed as thromboembolism is frequent. Ventricular underfilling does not respond to digoxin, Ditex or vasodilators. Digoxin may be used for rapid ventricular response in AF. If dyspnea is prominent, a case should be tried. Tachyarrhythmia may respond to low doses of beta blockers. Amiodarone may be needed during lethal arrhythmias. Resection of endocardial obliterating tissue and valve repair in EMF may cause symptomatic relief. Pre-op, top, and post-op, bottom, RV angiograms. In patient with biventricular EMF, characteristic, most pathognomic finding in obliteration of the RV apex with a residual bay-like formaton. After decorticatin, the RV becomes larger. Right ventricular cardiomyopathy. Arrhythmogenic right ventricular cardiomyopathy/dysplasia, RVC/D. Uncommon. Occurs in young and children. Male/female equals 2 to 3 1. Autosomal dominant. Pathology. Involve primarily RV. LV pathology is rare. Characteristic, segmentary, progressive, non-inflammatory myocyte loss, replaced by fat and fibrosis. Myocytes are replaced with fibrofatty tissue in RVC/D. Diagnosis, cine magnetic resonance imaging, CMRI. This can differentiate between normal and fatty myocardium. Morphologic changes can be detected. Regional and global ventricular dysfunctional abnormalities can be detected. Correlation between imaging and pathological tissue characteristics has been shown. ARVD/C, major and minor criteria. Major criteria. Familial disease documented on autopsy or surgery. ECG, epsilon wave or QRS duration greater than 110 ms and V, 1-3. Severe RV dilatation and systolic dysfunction. Mild LV pathology may or may not be present. Localized RV aneurysms, diastolic ballooning, localized dyskinetic or akinetic regions. Severe RV, segmentary dilatation. Biopsy, myocardium replaced by fibrofatty infiltration. Minor criteria. Family history of sudden death, less than 35 years. Family history of clinical diagnosis criteria. Delayed potentials, signal average DCG. T-wave inversion in V2,3 in the absence of RBBB. Greater than 12 years, ECG Holter, exercise testing, tachycardia with LBBB pattern. Greater than 1,024ths of an hour's VES. Mild RV dilatation/dysfunction, LV function normal/nenormal, mild RV, segmentary dilatation. Regional hyperkinesis of RV. Arrhythmogenic right ventricular dysplasia/cardiomyopathy, fatty tissue infiltrates RV free wall. This is seen in avenue groove. Microscopic view of RV free wall is seen at bottom. ARVD/C, ECG, epsilon wave is marked with arrow. ARVD/C, ECG, epsilon wave is marked with arrow. This is classic finding of ARVD. On right precordial leads, epsilon wave and T-wave inversion is present. There is conduction delay on right precordial derivations, dilated cardiomyopathy, DCM. Definition: chronic heart muscle disease characterized by cavity enlargement, getting spheric shape, and impaired global systolic function of the LV or both ventricles. 3. Specific property: 1. Decreased systolic function. 2. Global dilatation and or hypokinesis LV or RV. 3. If there is no CAD, congenital, valvular, hypertensive, specific heart muscle disease, and chronic alcohol consumption, in absence of these secondary causes, DCM must be considered in patients who have criterias 1+2. Alcohol does not cause dilated cardiomyopathy, but augments dilated cardiomyopathy. Past viral infection is the estimated diagnosis in %50 of patients. It was thought that some of the disease were of familial origin. Now the genetic origin is known. Patients are between 20 to 50 years old, but DCM may also be seen in children. HF begins as NIHA class 3 or 4 in percent 75 of patients. DCMP, essential processes, chronic volume overload, due to primary MR, idiopathic LV dysfunction, secondary MR, commonly ischemic origin. Last phase, LV cavity topography degenerated to spheric shape with manifest HF. DSM, post-remodeling, infarct expansion, plus non-infarct regions hypertrophy, plus global LV dilatation, plus HF. DSM, clinical presentation. Dyspnea, progressive exertional dyspnea. Signs of both LHF and RHF are common. Apical beat is replaced left, lateral and inferiorly because of LV dilatation. Left sternal impulse are palpable because of RV dilatation. JVP is raised and may show systolic wave of TR. Large V wave. Mr/TR, both Mr and TR murmurs of I3/4 degree may be heard because by the dilatation of both LV, RV, and the avenue annulus of the avenue valves both are dilate. S3 and S4, and sinus tachycardia are nearly always present. Summation gallop is a frequent finding. S3 is heard in nearly all patients and may also be present in the absence of heart failure. This finding differentiates DSM from ischemic SM. Mild S3 is heard in the presence of HF. In the absence of HF, and if LV aneurysm occurred, no S3 can be heard. BP is frequently low and is a sign of poor prognosis. Diastolic murmur is frequently absent. This finding rules out HF of specific origin, as are DSM, lab tests, ECG, sinus tachycardia, AF in percent 25. T-wave inversion or flattening. Mild LVH may be masked because of low voltage. Pseudo-infarct pattern, Q-wave, or poor R-wave progression in V24. Conduction disturbances in percent 75 of patients. Intraventricular conduction delay, LA, and in a small group, LBBB or RBBB, infrequently. Chest radiogram, tele. Cardiomegaly, frequently all chambers are enlarged. Pulmonary vascular evidence of left atrial enlargement, pulmonary venous congestion, interstitial edema, and pleural effusion. Echocardiography. Severe dilatation in both ventricles. F is generally between percent 10 to 30. Atrial enlargement and ventricular thrombus is frequently seen. Mild pericardial effusion is frequent. DCMP, ECG. DCMP, chest radiogram, tele. DCMP, lab tests, 2, endomyocardial biopsy, indications. To rule out myocardial disease, especially in myocarditis in which immunosuppressive therapy is planned. To diagnose viral particles. Pathologic properties, myocyte degeneration and necrosis, interstitial fibrosis, myocyte hypertrophy. In some patients, histologic findings are nonspecific. Interstitial fibrosis points out past viral myocarditis. Pathologic myocarditis diagnosis is made according to Dallas criteria. Active myocarditis, myocytolysis and necrosis near the regions of infiltration. Borderline myocarditis, increased infiltrates, without myocyte degeneration and necros. Holter monitor Saturn, helps diagnose lethal arrhythmias. DSM, prognosis. Previous viral infections is suspected up to percent 50 of patients. Cardiomegaly and reduced F is present in percent 20 of patients with DSM. In percent 26 of DSM patients autoimmune antibodies were detected, but less than percent 3 of these were known heart disease. Prognosis, 1-year mortality was percent 25. A K decrease percent 50 mortality, when was given early phase of HF. poor prognostic parameters. LV systolic function is the most important prognostic factor. 1 low F, or Einhauer class greater than or equal to 3, I is the worst prognostic factor. 2 echocardiography, global hypokinesis, F less than %20, spheric LV geometry, reduced LV mass volume, and RV dilatation. 3 clinical parameters, aging, history of syncope, S3 gallop, RV failure, AF, 1 or 2 degree avenue block, VT, LBBB.